गुड इवनिंग सर। प्रणाम।
क्या हाल चाल है?
मोस्ट पंक्चुअल चीफ ऑफ इंडिया।
हैं?
मोस्ट पंक्चुअल चीफ ऑफ इंडिया। इंडियन कॉलेज ऑफ फिजिशियंस एपीआई। आप सर दिनों ने दिन जवान होते जा रहे हैं। आप
जवान हो रहे हैं। ठीक, थैंक यू थैंक
जी
यू
जी
थैंक यू
जी जी।
थैंक यू।
स्पीकर के
ये
पहले
ना,
आप ज्वाइन कर लिए हैं।
असल में इस समय मेरा काम खत्म हो जाता है तो
जी सर जी सर।
फिर तो 8 साढ़े 8 बजे फिर ज्वाइन करना है।
हाँ फिर ज्वाइन करना है जी सर।
परसों 4 को ज्वाइन करना था मुझे। तंग
हाँ
तंग हो गए थे।
ने 24 को देखे ना, उधर हमको कर्नाटका वाले में ज्वाइन करना था एज ए पैनलिस्ट।
हम्म।
जैसे ही आए तो यहाँ शुरू हो गया। कई डॉक्टर डीपी सिंह मौजूद थे, बिल्ली बोल दिया कि नहीं है। हम बोले ही पी के तब आई एम फुल्ली विद दैट कि 5 मिनट पहले ही छोड़ करके आ गए हम। लेकिन
संजय जी
अच्छा
अभी
हो
आ
गया
रहे
सर उस दिन।
संजय जी अभी आ रहे हैं। कंग्रेचुलेशन संजय जी।
हाँ वेलकम डॉक्टर संजय, प्लीज अनम्यूट योर सेल्फ। अनम्यूट।
प्रणाम सर।
खुश रह खुश रह खुश रह। यही दिन देखना था हमको। यही
हाँ
दिन के लिए इतना मेहनत किए हैं हम।
एकदम सर, एकदम सर।
कि सब बिहारी पूरे हिंदुस्तान पर भारी।
एकदम सर, एकदम सर।
छाए छाए हुए हैं सर ना।
हाँ?
संजय जी, संजय जी कह रहे हैं छाए हुए हैं सर पूरे इंडिया में।
छाए रहना है और इनके छाया में हम लोग को छाए रहना है।
ऐसे ही बात है। तो इतना जो है ना, डेली क्लास वाला जो है, अब तक तो हम लोगों ने इतना दिन से है, 12-15 साल से एक्टिव एक्टिव है एपीआई में, कि इतना डेली क्लास हो।
नहीं, ये तो कॉलेज हो गया ना सर।
हाँ डेली क्लास क्लब कॉलेज का।
आईसीपी का मतलब है कॉलेज।
हाँ
आई सक्सेसफुल हो गया डीपी।
हाँ
ये
एकदम।
सर।
सक्सेसफुल हो गया।
जी।
देखते हैं ना, टीबी चेस्ट का वर्ल्ड टीबी डे मना रहे हैं, डेली चल रहा है, वो भी क्लासे हो रहा है।
वो भी चल रहा है वो भी चल रहा है।
आज फिर वर्ल्ड टीबी डे फिर मना रहे
आज से इसके
हैं।
बाद,
हाँ
आज फिर है इसके बाद।
हाँ हाँ वही तो। उसी दिन बोल रहे थे कि उस दिन मनाएंगे, हमको बोले कि जो है सुप्रियो को बोले, कोई खबर नहीं आया। तो देखे जी, अच्छा दो दो तो हम लोग, एक बिहार का था कर्नाटका का था, दोनों ज्वाइन कर लिए। और फिर बहुत अच्छा हो गया, अपना बिहार वाला भी बहुत अच्छा हो गया। करीब
अब
करीब 100 अटेंडेंस था सर उस दिन बिहार वाले में।
आए?
बिहार वाले में 100 अटेंडेंस था
हाँ था, अच्छा था अच्छा था।
सर।
अब एक और कोई टॉपिक सोचिए, हम सोच रहे हैं ऑल इंडिया लेवल पर।
और विषय में इतना काफी है सर।
ना ना, संडे के लिए, संडे के लिए। ये तो सोमवार से शनिचर न है।
हाँ
संडे,
हाँ।
संडे के लिए।
वेलकम डॉक्टर नैयर हमीद, डॉक्टर डीपी सिंह हियर। नहीं। So whether we shall start, time is
या सर।
Okay, time is going. So, 7:30. So I will ask Dr. DP Singh to say something and start the session. Dr. DP,
Mr.
please.
Anand, please post the CV of Dr. Sanjay Kumar. Sanjay Kumar is a well-known figure of API, ICP, this ICS, and as well as Indian College of Physicians. And he is at present the Joint Secretary of ICP and Joint Secretary of Indian College of Physicians. And he has got lot more. If there is one man, respiratory man from Bihar, Dr. Sanjay Kumar represents that. He is not only a member of ICP, API, this he is also a golden member of a European Respiratory Society. And he has got given a lot of training, whether it is this pulmonary function test, bronchoscopy, and many other things. Technicians he has trained, and he has got many publications, many book chapters in his fold. And I would ask Dr. Sanjay Kumar, he is going to deliver the very important topic, that is pneumonia. Pneumonia, as you know, William Osler used to say it is a old man's friend, and also the captain of man of death. Very deadly disease, especially in the immunocompromised patients and the elderly patients. And he has to cover the whole gamut of pneumonia within this 1 hour. Over to Dr. Sanjay Kumar for his talk or class on pneumonia. Sir.
Thank you, sir. I just share my slides. Thank you, sir, for your kind words. And really, it is a very big honor for me to deliver a lecture in this classical classes of Indian College of Physicians on the different topics, and respiratory is one of them. It is basically the brainchild of our Dean, Dr. Kamlesh Tiwari, sir. And I'm also thankful to him for showing his faith in me by nominating as the Joint Secretary from the Dean's place. So thank you, sir. So I would like to talk about a very common disease, that is pneumonia. I hope the slides are visible.
Yes,
Yes.
yes. Yes.
Okay. So I will be talking in the next 1 hour about the pneumonia. So just a minute. So the whole respiratory system is conveniently divided into upper and lower respiratory tracts, as all of us know. Right from the nose to up to the larynx, it is the upper respiratory tract, and below that, it is the lower respiratory tract. And the lower respiratory tract is very notorious in the terms that we get a lot of diseases in the lower respiratory tract. Pneumonia is one such, another is bronchitis, another is bronchiolitis, and lung abscess, and sometimes in pleura we also get diseases in the term like pleural effusion or empyema. So pneumonia is basically an infectious disease that may affect one lung or both lungs. And due to the infection, the air sacs or alveoli of the lung is basically being filled up with fluid or pus. And the infective organism can be any microbe like bacteria, virus, or fungi, and it gives rise to a lot of symptoms that I will come a bit later. So basically, it is an infectious disease that is being caused by bacteria, virus, or fungi. One or both lungs may be affected. What our respiratory system is constantly exposed to the outer environment as we breathe gases for our requirement. And so with the breath, we are very much liable to take the microbes that may enter into the airway and that may cause a disease. But the nature has provided a big army to protect us from those microbes. So the colonization of those microbes can be prevented, first by the mucus entrapment and the ciliary clearance, and the epithelial barrier of the whole system is a big protection mechanism that prevents the colonization, and so is the immune surveillance. A lot of protective factors are being secreted, like IgA, surfactant proteins like SPA and SPD, and defensins that protects our lung. Defensins are basically a short cationic peptides with broad antimicrobial and antiviral properties, and it is being produced by the neutrophil and epithelial cells. So all these mechanisms, in one way or in combination with others, protects our lung from the microbes. But if it is being disrupted in any way, we are likely to get the infection. How all this can be disrupted? First, there can be disruption of the mucociliary clearance, like in airway obstructions, or there may be ciliary dysfunctions like Cartagena syndrome, ciliostatic factors, or in smoking. Disruption of the epithelial barrier is also maybe a cause, like injury, either iatrogenically being caused by the intubation, or sometime by the diseases like pulmonary edema, or infections, either viral or bacterial. And there are conditions in which there is increased inoculation events. As the patient have altered consciousness, patient is debilitated, there is dysphagia, intubation, bacteremia, and decreasing immune function. All these may lead to colonization of the bacteria, microbes. Once the microbe colonize, what happens? It causes inflammation, either in the alveoli or in the interstitium. If there is inflammation of the alveoli, the alveolar lumen is filled with purulent exudates of RBC and polymorph neutrophils. So it causes the lungs to consolidate, and it may present as a lobar pneumonia or bronchopneumonia. Lobar, a whole lobe is being involved, while in bronchopneumonia, the distribution is patchy. On the other hand, if the interstitium is being involved, it is mostly the alveolar wall that is being affected by the inflammation, and there is mononuclear WBCs and there is fibrinous exudate. It usually causes atypical pneumonia, having the diffuse infiltrate in the X-ray, and it may be caused by the mycoplasma or the respiratory viruses like influenza. So it is the basic pathology of the pneumonia that goes on. And the pneumonia is being classified in two groups, community-acquired and nosocomial pneumonia. The division is basically on the temporal profile of acquisition of the disease, how the disease is acquired. If the pneumonia is acquired outside the healthcare settings, it is being called the community-acquired pneumonia. If the pneumonia is acquired in hospital setting, it is called nosocomial pneumonia, which can further be divided into hospital-acquired pneumonia, ventilator-associated pneumonia, and healthcare-associated pneumonia. If a patient is being admitted in the hospital, any sign or symptoms or any of pneumonia at the time of admission, but he or she acquires pneumonia in 48 hours or beyond that in hospital, it is called hospital-acquired pneumonia. And if a patient who is in hospital but does not have pneumonia develops pneumonia after the endotracheal intubation in a time of 48 hours or thereafter, it is called ventilator-associated pneumonia. And healthcare associated pneumonia is basically a pneumonia in patients who frequently takes healthcare assistance, like frequently being admitted into the nursing homes or get hemodialyzed at the hemodialysis centers or have frequent hospitalizations. If pneumonia occur in such a setting, it is called healthcare associated pneumonia. Coming to the community acquired pneumonia, it can be defined both on the clinical and the radiographic findings. In an outdoor setting, if there is no chest radiograph available, you can jolly well define pneumonia or you can jolly well diagnose pneumonia only on the basis of clinical findings. The clinical findings may be symptoms of an acute lower respiratory tract illness like cough with or without expectoration, shortness of breath, pleuritic chest pain that is for less than 1 week, and at least one systemic feature, that is temperature, high grade temperature more than 37 to 37.7 degrees Celsius, chills and rigors and or severe malaise, any of these. And new focal chest sign on examination. If you examine, you may find the new focal signs like bronchial breath sound or Krebs, and there must not be any other explanation for all these findings. So you can jolly well say that the patient is suffering from pneumonia even in the absence of radiogram. But try to get the radiograph as soon as possible. And on the radiographic findings, community-acquired pneumonia is defined as symptoms and signs as above with new radiographic shadowing for which there is no other explanation. As for example, not due to pulmonary edema or pulmonary infarction, such like that. So you can diagnose pneumonia, you can define pneumonia on clinical basis, on radiological basis. How big this problem is? If you go to the CDC estimates, about 1.1 million people in the US were hospitalized with pneumonia. And in 2009, out of those 1.1 million, more than 50,000 people died from pneumonia. So you can jolly well judge how big this problem is. If you go to the data regarding the epidemiology from all across the countries, right from the Asia, Australia, and South America, US, and Europe, everywhere this problem is very high, both in terms of the incidence and the mortality data is also very high if not being taken care of properly. So far, so the Indian scenario is concerned, the ICMR says that the number of deaths due to the lower respiratory tract infection was 35.1 per 1 lakh population in the year 2008. And the death due to TB in that period was 35.8 per 1 lakh population. So almost equal, the death due to TB and death due to other lower respiratory tract infections. While it was 194.9, the death rate was 194.9 per 1 lakh for infectious and parasitic diseases, meaning thereby around mortality due to the infectious disease in India is caused by lower respiratory tract infection. And community-acquired pneumonia mortality has been variably reported between 3.3% to 11%. WHO estimates says that about 150 million per year in children less than 5 years globally gets pneumonia. And pneumonia leading cause of morbidity and mortality, that is 1.4 million deaths per year. And in India, 23% of the global pneumonia cases are from India, and the case fatality rate is about 14 to 30%. Etiology. In cases of pneumonia, microbiological diagnosis is not always possible. Even to the best of the centers, it varies between 40 to 71%. But Streptococcus pneumoniae is the most common etiological agent. Viruses are second to the Streptococcus. It is around 10 to 36%. In India, the commonest organism, again, as it is globally, Streptococcus pneumoniae, about 35.3%, followed by Staph aureus, 23.5%, then Klebsiella pneumoniae, Legionella, Mycoplasma, and Haemophilus influenza. So these are the common organism, bacterial microbes. If you compare the data around the world, you can find that the diagnosis can be made, microbiological diagnosis can be made only in 40 to 71% of the cases. And again, the Streptococcus pneumoniae is commonest worldwide, while viruses coming around 10 to 36%. What happens in community-acquired pneumonia? It is the infection of the pulmonary parenchyma, as I have told earlier, acquired from the exposure in the community. And it is being divided into two types. Either it is typical or atypical syndromes. Typical is very much acute and severe. It is usually being called by Streptococcus pneumoniae or Haemophilus, and the causative agent may be identifiable, may be culturable, and it is responsive to the cell wall active antibiotics. While atypical community-acquired pneumonia is basically subacute, the causative pathogens are very much difficult to identify by standard methods, and it is usually not responsive to penicillins. The typical community-acquired pneumonia presentation, the patient remains healthy, but suddenly gets fever and shortness of breath. So they may have fever, tachycardia, tachypnea, productive cough with purulent sputum, and sometimes hemoptysis, or sometimes even the dry cough may be there. Patient may have pallor and cyanosis, and if you examine, you may find there may be dullness to percussion, and the breath sound may be sometimes decreased, and you may hear rhonchi or crackles like this, or egophony. You may also hear egophony. So these are the clinical findings that you may find. If you go for the investigation, chest X-ray, you may find the lobar consolidation. If you took the CBC, there may be leukocytosis with the shift to left. And the sputum sample may contain RBC, gram stain may be positive depending upon the organism that is causing the pneumonia. While a atypical community-acquired pneumonia presentation is very much subacute. As for example, in a 32-year-old healthy patient having 1 week of low-grade fever, sore throat, and intractable cough, having minimal sputum production, but he is able to continue his work. He doesn't have any sick contact in recent past, doesn't have recent travel, and there is no evidence of altered immune system. On physical examination reveals a mildly ill-appearing patient with diffuse wheeze on lung examination. Empirical antibiotics are being given, and there is complete resolution. So it is sometimes being called walking pneumonia syndrome also, because patient is mobile all the time, doing all the work, and he is having the pneumonia infections. The typical clinical features of community-acquired pneumonia include fever, cough, sputum production, dyspnea, and pleuritic chest pain. Physical examination may lead to hearing of the bronchial breath sound and crackles, and most important diagnostic armamentarium is the chest X-ray. If you get the chest X-ray, you may find asymmetric increase in lung opacification with air bronchogram, or there is presence of Silhouette sign. You must be knowing what Silhouette sign is. It is basically the organs in the thorax produce a sharp boundary. If that sharp boundary is being disturbed, that means there is something that is in contact with that organ. So it produces a Silhouette-like sign. So there may be presence of Silhouette sign. An area of increased opacity may be found bounded by a well-defined interface against adjacent aerated lung. And sometimes only if AP view is obtained, there may be increased attenuation of the cardiac shadow. Chest X-ray not only gives you a diagnosis of pneumonia, but also helps in differentiating from other causes of acute respiratory symptoms like pulmonary edema, pulmonary infarction, pleural effusion, etc. So try to get the chest X-ray as soon as possible. Next is how frequently the chest X-ray should be repeated, because nowadays we see that a patient of pneumonia is having so many chest X-ray. Is it necessary? No. Chest radiograph should be repeated if the patient is not improving, number one. And number two, for those patients who have persistence or worsening of symptoms or sign, or number three, in whom an underlying malignancy needs to be excluded. But if the patient is improving clinically, you need not to go for another X-ray. So it is not routinely necessary to repeat a chest X-ray in patients who have improved clinically. Nowadays, CT scan is available at most of the places, and sometimes we see that CT is also being done. The question is it to be done? If you go through the different studies, you may find that clinical utility of a CT chest in suspected community-acquired pneumonia with negative chest X-ray remain unclear. So the recommendation is that CT of the chest should be performed in those with non-resolving pneumonia and for the assessment of complication of the community-acquired pneumonia. It should not be performed routinely in patients with community-acquired pneumonia. Third question is whether to go for the blood or a sputum culture, yes or no. The recommendation says that the blood culture should be obtained in all hospitalized patients with community-acquired pneumonia. Blood cultures are not required routinely in outpatient management, and initial sputum gram stain and culture should be obtained only in all hospitalized patients with community-acquired pneumonia. But for that, a sputum quality should be ensured properly for interpreting the gram stain results. A sputum for acid-fast bacilli should be obtained as per the RNTCP guideline. And pneumococcal antigen detection test is usually not required routinely for the management of community-acquired pneumonia. The sensitivity of the culture and the sputum examination is high, but it is a specificity is not so. The result is not being obtained in most of the cases because the patient is already being treated with some antibiotics. So we may not get the results. There are certain general tests like full blood count and liver function tests that may helpful in the management of community-acquired pneumonia. But so far, so the outpatient is concerned, beside pulse oximetry and chest X-ray, there is no need of any more examination. If the pulse oximetry is again important because you can judge whether the patient is hypoxic or not, so that you can decide the severity of the cases. Blood glucose, urea, and electrolytes should be obtained, if possible, in OPD or in all hospitalized patients. Once you have diagnosed that the patient is having pneumonia, what is next? Next, you will have to decide how to manage. For that, first you will have to stratify the risk of the patient, because that will decide the level of treatment and accordingly the choice of drugs. There are a lot of risk stratification criteria, but the common criteria is Curve 65 and ATS IDSA criteria. The Curve 65 or CRB 65 criteria is very much easy, and you can jolly well score in your outdoor chamber. C stands for confusion, whether the patient is confused or mentally clear. Urea more than 7. If urea is not available, you can omit it, then it is CRB 65. Okay. Respiratory rate more than 30 or not. Low blood pressure, that is diastolic blood pressure less than 60, or systolic blood pressure less than 90. Age more than 65. And each of these elements has been given a score of 0 to 0 and 1. If not present 0, if present 1. So there are a score 0 to 5 in Curve 65 and CRB 65 0 to 4. 1, 2, 3. So you will have to score. If a score and is more than 1, you may need to admit the patient. If a score is 1 or more, you may need to admit the patient. Once the patient is admitted, then you will have to decide whether to treat the patient in ward or patient in the ICU. For that, ATS criteria is very helpful. It has been divided into the major criteria and minor criteria. The major criteria is 2, that is invasive mechanical ventilation, need, and features of septic shock with need for vasopressors. The minor criteria are high respiratory rate, more than 30 breaths per minute. In ABG, PaO2 by FiO2 ratio less than or equal to 250. X-ray multi-lobar infiltrates, confusion or disorientation, uremia, that is high burn level, more than 20 milligram per deciliter, leukopenia, WBC count less than 4,000 cells per cubic millimeter, thrombocytopenia, platelet counts less than 1 lakh, and hypothermia, that is the core temperature less than 36 degrees Celsius. So you will have to risk stratify. Curve 65, if a score is more than 1, patient should be considered for admission. Once selected for admission, can further be triaged to ward or ICU based on the ATS IDSA criteria. That is any of the major criteria, either of the two. If any of the major criteria is present, or at least 3 minor criteria is present, the patient qualifies for an ICU admission. Otherwise, you may manage in the ward. So, in nutshell, if a patient having cough with or without expectoration, shortness of breath, pleuritic chest pain for less than 1 week, with at least one of the systemic features, that is high-grade fever or chills, rigor, etc., or new focal chest signs on examination with no other explanation, try to get the chest radiograph. If chest radiograph is not available, even then you calculate the CRB 65 criteria. If it is less than 1, check oxygen saturation using pulse oximetry. If the patient is less than 50 years of age and the oxygen saturation is less than 92%, patient is hypoxic. But if the patient is more than 50 years of age, the saturation is less than 90, only then the patient is hypoxic. If patient is not hypoxic, manage on the outpatient basis. But if the if the curve score is more than 1 or the patient is hypoxic, admit to the hospital, get the chest radiograph, send the samples for urea electrolyte, full blood count, arterial blood gas, etc. Administer first antibiotic dose, then decide on the ICU or non-ICU admission. Just a minute. And if admitted to ICU, obtain liver function test, creatinine, Legionella, urinary antigens, etc., and then manage accordingly. Or if the chest radiograph is available, you see for the lobar or patchy consolidation, loss of normal mediastinal or cardiac or diaphragmatic Stillhut, perihilar opacity, or interstitial infiltrates with other causes of the conditions ruled out clinically. If all these are absent, you consider alternative diagnosis, or if present, then again go through the curve scoring and further manage. So next is, since it is being caused by the microbes and the commonest is the bacteria, that is Streptococcus pneumoniae, we will have to give the antibiotics. So empirical antibiotic therapy is usually recommended because isolation of the organism in large proportion of patients at the very outset is not possible. So give empirical antibiotic, and that therapy is to be targeted against the commonest organism, that is Streptococcus pneumoniae. The recommended antibiotics are oral macrolides or beta-lactams. Sometimes combination therapy with beta-lactams and macrolide in outpatients with patients having comorbidities may be needed, but there is no recommendation for first-line use of tetracycline or fluoroquinolones. The drugs commonly used are amoxicillin, coamoxiclav, azithromycin, ceftriaxone, cefotaxime, cefepime, ceftazidime, piperacillin tazobactam, imipenem, and meropenem. The practical guideline from the PGI Chandigarh says that in Indian setting, the most appropriate treatment is in the outpatient setting would be a beta-lactam plus a macrolide. The indication for empirical therapy in the outpatient settings are the antibiotics should be administered as early as possible because timing is very vital. The patient may become serious if you don't give antibiotic immediately. And the therapy should be targeted, as I have told earlier, towards the coverage of the most common organism, that is Streptococcus pneumoniae. Outpatient patient, then stratify the patient with having comorbidities or without comorbidities, and recommend antibiotics are, as I have told, if the outpatient oral macrolide, that is azithromycin or others, or oral beta-lactams, as for example, amoxicillin or amoxicillin clavulanic acid combination. That too without the patients, without comorbidities. If the patient have other comorbidities, oral combination therapy is usually being recommended, that is beta-lactam plus macrolide. Antibiotics should be given in appropriate dose to prevent emergence of resistance. Otherwise, there is chances of resistance emerging is very high. What are the comorbidities that we must see for? Chronic heart disease, chronic lung disease, chronic liver disease, or chronic renal disease, diabetes mellitus, alcoholism, malignancy, and previous use of antimicrobials within the previous 3 months. This is very important that all of us miss. We do not take the previous drug history. So it is very important. And severe community-acquired pneumonia, even without comorbidities, they may need empirical combination therapy of beta-lactam plus macrolide. Once the patient is triaged to be hospitalized, and that too in the ward, not in ICU, the, the, the treatment regime may vary. You will have to give a combination of beta-lactam plus macrolide, and sometime if the patient is hypersensitive to beta-lactam, only then you may try respiratory fluoroquinolones. But you must be clear that tuberculosis is not a diagnostic consideration at admission. And if you give the fluoroquinolones, first send the sputum sample for AFP. Next, if the patient is admitted, the route of administration can be oral or parenteral. And it should be decided on the clinical condition of the patient and your judgment regarding the tolerance and efficacy of the chosen antibiotics. So whether the patient is able to take orally or not, it is also very important, and you will have to judge whether to give it in the parenteral will benefit more or not. If the patient is in ICU, you will have to do the beta-lactam plus a macrolide for the patient without the risk factor for Pseudomonas. But if Pseudomonas is an etiological consideration, you will have to give anti-pneumococcal, anti-pseudomonal antibiotics like piperacillin tazobactam, cefoperazone sulbactam, imipenem, or meropenem. Sometimes combination therapy may be considered with addition of aminoglycoside, anti-pseudomonal fluoroquinolones, as for example, ciprofloxacin. But again, you will have to be very much cautious about the tuberculosis and send the sputum sample first. Antimicrobial therapy should be changed according to the specific pathogens isolated. Diagnostic or therapeutic intervention may be done for complication. As for example, there may be parapneumonic effusion, so you will have to do the thoracocentesis, or sometimes chest tube drainage may be needed. If a patient does not respond to treatment within 48 to 72 hours, what should be done? The patient should be evaluated again for the cause of non-response, including the development of complication or the presence of atypical pathogens or drug resistance. You will have to look for that. So the initial treatment strategy for inpatients with community-acquired pneumonia by level of severity and risk factor for drug resistance can be non-severe inpatient pneumonia. The standard regime is beta-lactam plus macrolide. But if there is prior respiratory isolation of MRSA, you will have to give an MRSA coverage, coverage against MRSA also. If there is severe inpatient pneumonia, beta-lactam plus macrolide or beta-lactam plus fluoroquinolones, and you will have to look for the MRSA status, and I'll also look for the Pseudomonas chances, and you will have to cover that also. In the last ERS, so 2024, there are certain recommendations on the treatment and the treatment period by the ERS. They emphasize a reduction in the duration, how long the antibiotics to be given. They have emphasized not a long-term treatment. Rather, they emphasize a reduction in the duration of antibiotic treatment based on the clinical stability. If the patient meets the stabilizing criteria within 3 days, antibiotic therapy can be discontinued at that point. Or if the stabilization criteria is between 3 and 5 days, therapy should be stopped after 5 days. And in cases where even stabilization is not achieved by 7 days, treatment should continue for a maximum of 7 days unless complications such as emphysema or pleural effusion are present. Otherwise, they emphasize a stoppage of the antibiotic. Their recommendations for the fluoroquinolones again, they said that fluoroquinolones should not be used at the first line treatment. Instead, amoxicillin or amoxicillin clavulanic acid should be administered to non-ICU patients. Nowadays there is a big question regarding the use of corticosteroid in severe community acquired pneumonia. At some centers it is being given, but the issue is very much controversial as there is no definite studies. Whatever studies are available, they are underpowered for mortality and they have very early termination. They were open label, no allocation concealment, and unbalanced group regarding the severity of the disease, and the patient of the COPD patients were also included. So the studies are not good enough for a standard recommendation. The ERS 24 says that while they are not recommended, cortisone are not recommended for ambulatory or non-severely hospitalized patients, they may be considered for severe cases or those in intensive care. And if you will have to give, the drug of choice is hydrocortisone hemisuccinate. It should be administered at a dose of 200 milligram per day in divided dosage, that is 50 milligram 4 times daily, and adjusted based on the patient response with a maximum duration of 8 to 14 days. And this approach is basically aligned with the practices that is being done for the septic shock management. That is, cortisone is to be given. Next, we will have to decide regarding the transition of the patient with CAP from parenteral to oral. When to stop injection and to start oral. The criteria are when the patient is able to ingest oral drugs, heart rate is settled or going down to less than 100 beats per minute, and systolic blood pressure is coming up to more than 90 mmHg. Patient's hypoxia is improving to the saturation more than 90%, and the partial pressure in the ABG is more than 60 mmHg on room air, or with low flow supplemental oxygen via nasal cannula, or return to the baseline oxygen level for patients receiving long-term oxygen therapy, like in chronic COPD patients. Respiratory rate is going down to less than 25 breaths per minute. If the patient sensorium was not clear, he is returning to the baseline cognitive status, and temperature is going down. And mind it, all these criteria should be met for at least 24 hours before switching to oral antibiotics. It is not that you get one and you immediately switch. You will have to wait that the criteria are met for at least 24 hours. Next is to decide when to discharge the patient from the hospital. The recommendation is the patient start accepting orally, patient is afebrile, patient is hemodynamically stable, that too for a period of at least 48 hours, and there is no need for medical care to any other comorbid conditions. Only then you should discharge the patient. There are certain changes from the earlier recommendations by ERS. In contrast to the previous guidelines from 2010, the new recommendations highlight the importance of imaging. So imaging is recommended if feasible, ideally conducted as soon as possible or within 3 days of initiating antibiotics. Systematic use of C-reactive protein and procalcitonin, that is the biomarkers, is not advocated. Regardless of whether the patient is ambulatory or hospitalized, antigen testing is recommended only in cases of severe illness or if there is significant suspicion of Legionella. Respiratory samples are to be limited. However, complete blood count remains recommended. So in this way, you can manage the community-acquired pneumonia in a better way, and most of the patients are well with this type of treatment, and the mortality rate is also low. But it is always better that the disease is prevented. So nowadays there is a concept of adult vaccination also, and pneumonia is one such disease. In 2015, Advisory Committee on Immunization Practices in US recommend that all adults 65 years and older receive both the 13-valent pneumococcal conjugate vaccine, that is PCV13, and 23-valent pneumococcal polysaccharide vaccine, PPSV23, preferably with PCV13 administered first, followed by PPSV23 in 12 months. But if PPSV23 was already given after the age of 65, you will have to wait for 1 year and then get PCV13. When PPSV23 is administered before age 65, PCV13 should be offered if at least 1 year has elapsed, followed by another dose of PPSV23 after at least 12 months, and if at least 5 years have been elapsed following the previous PPSV23 dose. So there are two vaccines, PPSV13 and PCV13. Preferably give PCV13 first, then PPSV23. Indian recommendations by the different societies like Indian Chest Society, RSSDI, and Geriatric Society of India slightly varied. As per the Indian Chest Society, pneumococcal vaccination is usually not recommended for healthy adults under 65 years of age, while RSSDI consensus group in 2022 says that all diabetes subjects should be educated about administration of at least pneumococcal and influenza vaccine. People with diabetes aged 2 to 64 years should receive a 23-valent pneumococcal polysaccharide vaccines. At age more than 65 years, regardless of vaccine history, additional PPSV23 vaccine is necessary. While Geriatric Society of India says that vaccinate individuals aged 50 years and older. So there is slight difference, difference in all these recommendations, but in a nutshell, we will have to vaccinate the older people or younger people with having the comorbidity. In general, high-risk groups in whom vaccinations are recommended are either chronic cardiovascular, pulmonary, renal, or liver disease, patients with diabetes, patients having CSF leak, alcoholic patients, patients having asplenia, and the immunocompromising conditions or having drugs that causes immunocompromised conditions. In all these groups, it is highly recommended that pneumonia vaccine is being given. The Indian guidelines are different from the American guideline in terms of recommendations regarding vaccination with PCV13 vaccine. The American guidelines are basically based on the fact that in USA, PCV13 is being administered to all children since the year 2010. And therefore, some sort of herd immunity is there, which prevents adults from being affected by the 13 serotypes covered by PCV13. But in India, pneumococcal vaccination in the pediatric immunization schedule has only been incorporated very recently. So the concept of herd immunity is not applicable here. Hence, in the current guideline, for individual aged 19 to 64 years and with health conditions as stated above, we recommend vaccination with PCV13 followed by PPSV23. So in order to conclude community-acquired pneumonia, it is the prominent cause of mortality and morbidity with important clinical impact across the globe. Community-acquired pneumonia can affect patients of all ages and across all spectrum of health, with most of the hospitalization occurring in older patients. Clinical manifestation can range based on the etiology of CAP, but sputum production tends to be the most significant manifestation in typical pneumonia. Recent studies have shown that Legionella disease can have similar radiographic and tomographic manifestations that are similar to those found in typical CAP, and the proper diagnosis of Legionnaire's disease rests upon the laboratory-based diagnostic test, plus the clinical and radiological diagnosis of pneumonia. Management of CAP tends to be empirical antibiotic, which can present with risk factors. However, with proper risk stratification technique, such as curve criteria and ATS IDSA criteria, we can better guide the antibiotic treatment. Next is the hospital and the ventilator-acquired pneumonia. As per the IDSA guideline, hospital-acquired pneumonia, as I have already told earlier, is the pneumonia that occurs 48 hours or more after admission to the hospital and did not appear to be incubating at the time of admission. While ventilator-associated pneumonia is defined as pneumonia that develops more than 48 to 72 hours after endotracheal intubation. Mind it that it is written endotracheal intubation, not connection to the vent. So patient is even endotracheally intubated and develop pneumonia, you will have to mark it as the ventilator-associated pneumonia. The incidence of the hospital-acquired pneumonia varies from 9 to 58%, and mortality rate is very high, from 30 to 70%. In India, it has been reported a higher incidence density of ventilator-associated pneumonia of 39.6 to 40.1%, and several prospective and retrospective studies across India have found that these infections are associated with significant morbidity and mortality to the tune of 16 to 74%. So it is a very big problem. There are a lot of risk factors, both host and others. The host factors, that is, it is more common at the extreme of age, or the patients having severe acute or chronic illness, having immunosuppression, patient is in coma, alcoholic, malnutrition, COPD, and diabetes mellitus. There are factors which can enhance colonization of the oropharynx and the stomach by pathogenic microorganisms, like admission to an ICU, administration of antibiotic that disrupt the gut flora, chronic lung diseases, endotracheal intubation, conditions favoring aspiration or reflux. If the patient remain in supine position for quite long time, or the patient's consciousness is depressed, or patient is endotracheally intubated, or there is insertion of the nasogastric tube, these conditions may favor aspiration or reflux. There may be mechanical ventilations, and in that condition, the mucociliary function may be impaired. There may be injury to the mucosa, and that the epithelial barrier may be disrupted, so there may be more bacterial binding. There may be pooling of secretion in the subglottic area, so more colonization can occur. There may be potential exposure to the contaminated expiratory equipment. So if there is some equipment may harboring some microbes, and contact with the contaminated or colonized hands of the healthcare workers is again very important factor. So hand washing should be promoted all the time in the ICU and the hospital wards. There are factors that may impede adequate pulmonary toilet, like surgical procedures that involve the head and neck, patient in being immobilized as a result of trauma or illness, or patient is being sedated due to any cause. The etiological factors is different from that of the community-acquired pneumonia. Here, the commonest factor is Staph aureus, followed by Enterobacteriaceae, then Pseudomonas, Actinobacter, polymicrobials, anaerobic bacteria, Legionella, Aspergillus, and viral. Yes, sir. Yeah. Yeah. So you will have to diagnose either clinically, radiologically, or lab or microbiological, and or the quantitative cultures. The problem are multifold, that there may be difficulty in diagnosis, and there may be the multi-drug resistance. So you will have to diagnose either through the culture or by bronchoscopic sampling of the respiratory secretions. So once it is diagnosed, it is always you will have to treat accordingly. Here again, you will have to give the antibiotic, and you will have to look for the other organs also, whether the kidney is functioning properly or not, liver is functioning properly or not, because there may be the multi-system disorder, and you will have to give the antibiotic as per the condition. ICMR suggests that empirically for VAP or HAP, the preferred antibiotic is cefoperazone sulbactam, piperacillin tazobactam, etc. But sometimes you will have to give the meropenem, imipenem, ceftazidime, etc. The others are levofloxacin, or you may have to give the drugs against MRSA, that is vancomycin or teicoplanin and linezolid. So you will have to give the patients and these antibiotics for the sufficient time, preferably in the empirical regime is to be followed. And then you try to find out the specific organism and the culture sensitivity, and then manage accordingly. And again, you will have to de-escalate the treatment as soon as possible. And you will have to manage the other organs also. So it is just the brief outline of the ventilator associated or the hospital associated pneumonia. It is a very big chapter. So I just give the brief outline and how to diagnose and how to manage. Thank you for hearing.
So thank you, Dr. Sanjay ji, for the excellent deliberation. And there are a lot of things that you have to tell. Any questions in the chat box from our? No questions. There is questions. Yeah.
Sir,
when do we vaccinate post pneumonia? What is this question? Kindly take some questions from the chat box.
Okay, sir. I try to. Since API function is just getting started at 8:30, so I will have to hurry up. Actually,
sir, I have a question, sir.
You just write down the question in the chat box. One question is, how long corticosteroids should be used in aspiration pneumonia, as it will decrease inflammation but can aggravate the association? The recommendation for corticosteroid is very much specific, that it is to be given only in the certain conditions if the patient has severe pneumonia and or the patient is having septic shock. And you will have to give the antibiotic in hydrocortisone hemisuccinate 200 milligram in 4 divided doses, and that too from 10 to 14 days only. Not to give much for much time, but the studies are very limited. There is no such a study that can say that it is to be given for that particular time. So a study is very limited. A lot of studies are going on, but presently it is to be given for 10 to 14 days.
Thank you, Dr. Sanjay. Whatever questions are there, Anand, please take it and put it on the group, and Dr. Sanjay will later answer it.
Yes, I will answer.
Yes, sir. Yes, sir.
Yeah.
Sure, sir.
So
Sure.
take all questions, whatever there, And because we have got one API meeting just now, so we are going to join that meeting. Thank you very much. Thanks, Dean sir, Tiwari sir, and thanks Dr. Amit and all those who joined. Thanks.
Congratulations, Sanjay boss, for a wonderful lecture.
Wonderful,
I think
wonderful. Yeah.
this needs to be YouTubed.
Thank you.
All the best. Goodbye. We shall join the API meeting just now.
Okay. Good night.
Good night, sir.